Hello guys, today we will be discussing about hysterosalpingography. It is the most common method to test tube for tubal evaluation. Usually HSG is the most commonly done investigation. So the indications for HSG are infertility. Infertility is the most common indication, that is for the tubal evaluation. As I already told, the HSG is done. Second is recurrent pregnancy loss. So why in RPL we need to do the HSG? Because apart from assessing the tubes, HSG is also helpful in assessing the uterine contour, any uterine abnormality like any septum, polyp or anything. It can be an easy and you can say cost effective method to check for all these things. So third is preoperatively for before evaluation, preoperative evaluation prior to myomectomy, it can be used. And fourth is post-operative evaluation following recanalization. So following recanalization, after say 3 months, we can check for the tubal patency. There are some contraindications when the HSG should not be done. First is active PID. Anytime the PID is there, at least for 3 months we should not do HSG, because that will lead to exacerbation of that infection which is already there. Third is premenstrual phase. HSG, when the HSG is done, usually HSG is done in the postmenstrual phase, usually day 7 onward we can do it. In the premenstrual phase we should not do, because we do not know whether the patient can be pregnant also. So, and if it is pregnant, you will be giving unnecessary exposure of x-rays to the patient, and moreover the pregnancy dislodgement can happen. So that's why in premenstrual phase we should not do it. Third is pregnancy undiagnosed. Anytime it can be, like if it is ectopic pregnancy or any pregnancy of unknown location, anything, whenever the pregnancy is there, HSG is totally contraindicated. Sensitivity to contrast media, obviously. And recent DNC, so again that exacerbation of the infection can happen. You are introducing something which can lead to infection, so that's why recent DNC we should not do. And severe renal or cardiac diseases, because of that contrast issues, we should not do in these comorbid conditions. So what is the best time to do HSG? Ideally HSG should be done after at least the periods should stop, like 2-3 days the periods have stopped, then only we should do the HSG. It's not like on day 7 or day 8. Sometimes the patient has prolonged periods, and those patients you cannot, all the patients you cannot tell like HSG should be done on day 7 or day 8. Usually 2 to 3 days after the periods have completely stopped, we should do the HSG. And it is done in the, as I already told, in the postmenstrual phase. There are 2 reasons why we do in the postmenstrual phase. First is the pregnancy is definitely ruled out, because in the postmenstrual phase patient is not pregnant. And secondly, because there is no chances of pregnancy, the X-ray exposure is the something which we want to avoid, because in the same cycle patient can get pregnant. So that's why we tell patient to have abstinence in the cycle when the HSG is being done. So coming on to the pictures, so I will be showing you some pictures of HSG. So this is the normal HSG. So here you can see this is a uterus, and here are the tubes. So as you can see, these are the, and here the free spill is there. This is one side, the free spill is there, free peritoneal spill, and this is the other tube where the free peritoneal spill is there. You cannot tell whether it is right or left unless and until the marking is there. Usually you will be seeing one marking over the HSG. There will be a left or right, like it would be written like right, R or L. So that tells which side of HSG is. So this free peritoneal spill is there. It means this is a normal HSG. So this picture I have specifically put, what is the problem in that picture is, see, this is the uterus. It is, although it is normal uterus, but still it is not appearing like normal. This is the early filling phase of HSG. Why it is appearing like this? Because the proper traction has not been given. So proper traction is very important whenever you are doing the HSG, because otherwise, because normal uterus is either anteverted or retroverted. So it's very rare to find a midline uterus. Mostly they are either it is sitting on the bladder or it is sitting on the rectum. So that's why we have to give a proper traction for the proper uterine contour to come. So that's the reason I put this particular picture. Second, now you can see here proximal tubal blockage. Here you can see this is the uterus, the cavity is normal, but here the cornal spasm has happened, or there can be actual block. So we cannot make out whether it is the proximal tubal blockage is because of any physiological blockage and physiological spasm, or there can be any debris, or there can be any mucosal plug. So all these things can be there, so that we cannot make out. But in this, seeing this HSG picture, the what we can infer is there is proximal tubal blockage. Now this is the picture showing distal tubal blockage. Here you can see this is right hydrosalpinx and this is the left hydrosalpinx. Okay, so this is the picture with bilateral hydrosalpinges. Usually HSG, it is more specific for the distal tubal blockage as compared to the proximal tubal blockage, because proximal tubal blocks can happen because of cornal spasms also. So it doesn't mean if the proximal tubals are shown being blocked like here, it doesn't mean that 100% that HSG is normal. What is seen in many cases, in like 60% of the patients, if the same patient we have done laparoscopy, this tube will be shown as patent. So that's why HSG is not very sensitive for proximal blocks as compared to the distal blocks. So this is now the one uterus, which is here you can see this X-ray picture in which you can see there is some depression over here. So this is most likely suggestive of arcuate uterus. So this is a picture in which you can see this depression and the tubes are open. This is another picture I have put to show you how the septate uterus looks like. Like here the depression is not so much, but here you can see the depression is, it's totally coming up to the more full of the cavity only, almost it's occupying. So this is the septate uterus, and this is the bicornuate uterus most likely. Why it is bicornuate uterus, not septate uterus? And you can see there these two horns, they are markedly splayed. So this marked splaying of the uterine horns makes it different from the septate uterus. As here you can see the horns are not so far, but here you can see the horns are very far. But 100% we cannot diagnose on HSG because we cannot see, as long as we cannot see the fundus, we cannot make out whether this is bicornuate uterus or it is a septate uterus. The septate uterus or bicornuate uterus can only be made out on the 3D ultrasound or on the, if simultaneously laparoscopy we are doing. So that is the only way we can make out. So these days, because 3D ultrasounds have come, so we need not to do the invasive procedures like laparoscopy. With 3D ultrasound you can easily make out whether this is bicornuate uterus or it is septate uterus. So here you can see the unicornuate uterus. This picture is showing like unicornuate. This is a typical unicornuate, like banana like uterus. So this is the tubular picture if you see on the radiograph, and one tube also you can see along with it. This is a typical banana picture. So this is a unicornuate uterus. Okay, here also you can see this tubal spill is there, and this is a banana kind of picture. So it's a tubular image of the uterus suggestive of unicornuate uterus. So here you can see the air bubbles. Whenever this you see air bubbles which are getting collected on one side, mostly it is because of the some blockage over this particular cornua. So it can be tubal blockage, proximal tubal blockage, that air bubbles, or they can be physiological also when you do not take care while putting the dye. That time also the air bubbles can come. Here you can see this the filling defect. So usually one thing we should take care, that filling defects are mostly seen during the filling phase of HSG. Once the HSG is once you are filling, like here you can not see the tubes. So it means it is just the filling phase. It can be block also, but it is the filling phase. This radiograph was taken during the filling phase of HSG. So during that time, all these SOLs can be seen very clearly. All the small polyp, all the small fibroids, they can be seen very clearly. But as we fill the uterus with the contrast, the small space occupying lesions, they might get obliterated. So it is the filling phase is the best phase to see the uterine SOLs. So here, as you can see, these are the small you can see these glandular outpouchings are there. So this is a sign of diffuse adenomyosis. As you can see here, the irregularities are there over it. Okay, so small outpouchings of contrast material you can see. So this is a sign of irregular endometrium with the small outpouchings. This is a sign of diffuse adenomyosis. Here in this picture you can see the tubal polyp. Here you can see this is a tubal polyp. Here also clearly it is a tubal polyp. So some dye has gone through this tubal polyp to the tubes, but this tubal polyp is clearly seen over here, and the small can be seen over here. So this is a typical picture which is showing the tubal block post tubal ligation. As you can see here, the tubal ligation has been done. This abrupt ending of the contrast media. So abrupt ending of the contrast media is suggestive of tubal ligation, tubal block post tubal ligation. This is a picture showing salpingitis isthmica nodosa. What is salpingitis isthmica nodosa? In this, as you can see here you see there are outpouchings or diverticula from isthmic portion of the tube. So this is the interstitium and this is the isthmus. After that the ampulla will come. So here you can see these small the outpouchings. So these are suggestive of salpingitis isthmica nodosa. Here you can see the niche. What is niche? When it is the sign of previous cesarean section where we give the incision. So there sometimes the collection of the menstrual fluid can keep on happening, and patient might present later on with abnormal uterine bleeding or continuous bleeding, or there can be recurrent infection. So that can be seen in ultrasound, in HSG. Uterine synechia. So uterine synechia, here you can see this is a typical honeycomb appearance. Here you can see there are so many uterine synechia. So endometrium is totally converted into a honeycomb. So that uterine synechia can be post TB, or there are many other infections which can PID. This can lead to uterine synechia, or specifically when vigorous DNC is done post pregnancy, post abortion. So that can lead to Asherman syndrome. So that will appear like this on HSG. Next is contrast extravasation. Here you can see this contrast where it has gone into the, here you can see it is all in the vessels, it has gone. So this is the contrast which is coming out because it is mostly seen in the patients with like a tuberculosis. So this contrast, when we are putting the contrast and very forcefully and there is blockage, so the contrast can go into vessels, sometimes into even in this you can see the ureters it can go. So it is the typical picture showing the contrast extravasation. So thank you.